Thank you, everyone, and thank you for the invitation to come talk. So I'm going to be talking about a case that started as a structural case, quickly turned into a peripheral case, in which our small axis actually saved us from complications related to our large axis. For me, I think as a general cardiology fellow entering the field of interventional cardiology next year, the focus of my talk is more on good principles for the procedure as opposed to more the nuances related to equipment selection. So we'll start with our case. We had an elderly woman with a history of heart failure and severe aortic stenosis who was referred to us for TAVR evaluation. TAVR pre-op evaluation showed that she had no calcium in the left ventricular outflow tract, adequate coronary heights. A left heart cath showed single vessel disease in the RCA that was medically managed. CT of the abdomen and pelvis showed adequate caliber of the iliac and femoral arteries and an overall low surgical risk score. So we brought her in to perform the TAVR. We start the case with our bilateral femoral axis. At our institution, we do an ultrasound-guided micropuncture stick, followed by an angiogram to ensure that we have good access above the level of the bifurcation, but not too high so that you can still compress if you have any kind of bleed. I'm showing you the left, but the axis was the same on the right side. The right side was the side where there was a large bore axis. Fast forward, we'll skip the structural details. The patient ultimately got the TAVR, which was successful. There was no residual gradient and no paravalvular leak. And everyone was happy, so we proceeded with closure of the large bore axis using a MANTA device. Obviously, the case was not over at that point. When we took a shot of the right side, again, this is where the large bore axis was. This is what we saw. So if you see here, we have completely occluded the area of the iliofemoral artery on the right side. So then we had to stop and think about what to do next. Do we call vascular surgery to help bail us out, or do we have some sort of endovascular therapy to help reestablish flow here? So we proceeded with attempting an endovascular therapy at this point. The way we did that was through the contralateral side. Again, this was the small axis on the left. Using the left axis, we fed a wire up and over onto the right side, and then put an Ansel sheath into the distal end of the external iliac artery. And when we shot the angiogram, what we saw was that there was a complete occlusion at the level of the common femoral artery. We tried crossing the lesion via an antegrade fashion, as you can see here with the guide wire through a microcatheter. But despite multiple attempts and multiple wires, we were unable to cross the lesion. It appeared that the guide wire would enter the subintimal space, so we were not able to access the true lumen via antegrade fashion. Again, we're at a crossroads. Do we try a different endovascular approach, or do we call vascular to help us out at this point? We decided to do a retrograde approach here. So what we did here is, again, using ultrasound, we gained access to the right SFA using a micropuncture catheter. The micropuncture catheter was inserted and a long wire was placed up and through the lesion and externalized via the Ansel sheath to the contralateral side, thereby establishing access to the true lumen via retrograde. And this is just a picture of what that setup was, right? We have the micropuncture catheter. We essentially just attach the copilot at the end of that. The distal port is just closed with a stopcock, and then we have the long wire coming through the distal tip of the copilot. Now that we've gained access to the true lumen, onto that long wire that we externalized through the left femoral, we put a balloon, and then we came back toward the right side. You can see here the video, we're feeding the balloon coming down. We ballooned the lesion, which you can see there. The balloon is inflated, but unfortunately not fully dilating the occlusion. We take another angiogram. We're a little bit more relieved at this point. We reestablished perfusion to the leg, but as you can see, there's incomplete dilation of the lesion. So now, having established access to the true lumen, we could have better characterization of the lesion. Well, let me back up, actually. Can we back up one slide? Essentially, what we did was, using IVUS, we characterized the lesion and realized that the problem was that the manta foot plate was stuck within the lumen of the artery. And so what we did then was we decided to do an atherectomy and thrombectomy on the lesion. In order to do that, we first closed the access at the SFA. The way we did that was by balloon tamponading the arteriotomy. Essentially, what we did was bring that balloon that I mentioned earlier, we advanced it antegrade past the lesion, and the long wire that we had fed in the retrograde fashion was brought back. And both of these were retracted slowly until you saw the interaction between the balloon and the wire. And at that point, you would pull the guide wire out and inflated the balloon to tamponade or arteriotomy. After that, we then put a filter at the proximal end of the SFA to prevent any kind of distal embolization. And we proceeded with our thrombectomy and atherectomy using a Boston Scientific jet stream device. You see here the device making multiple attempts at crossing the lesion until it finally gives. So we reestablish access and completely dilate that lesion. Our final shot, finally we see good distal perfusion to the leg, no perforations, and no need for any stents at this time. So just some take-home points for me as a general fellow. The first is that the large bore on these cases always closes first, because then you have your small axis that can bail you out in case you run into any issues. Always image the contralateral side after closure. And you don't assume that you're done with the case until you are completely done with the case, which also means that you don't jump the gun and reverse the heparin before you completely remove all of the equipment and you see that the axis side is completely closed and properly. And lastly, digital subtraction is key in identifying any kind of complication. And that's it.